acute tubular necrosis, which is synonymously also known as acute renal failure, right, or acute kidney injury. It comes under tubulointerstitial disease. Before this, in very initial classes, we have talked about glomerular disease, isn't it? Glomerulonephritis, glomerulosclerosis, the cause of nephrotic and nephritic syndrome, right? We have already talked about glomerular disease. Now we are talking about tubulointerstitial disease. So, acute kidney injury or acute tubular necrosis leading to acute renal failure is related to tubulointerstitial disease, meaning the glomerular disease may give a patient some time, okay, for either recover or to sink, while tubulointerstitial disease can be very acute. Now, many students get confused with acute renal failure and the difference between acute renal failure and acute tubular necrosis. So they are little synonymous because ultimately acute kidney injury or acute tubular necrosis lead to acute renal failure eventually. So if we ask you the pathogenesis, the cause, or whatever questions related to acute renal failure, you have to mention acute tubular necrosis. Clear? Now, in overall heading of tubulointerstitial disease, one is acute kidney injury or acute tubular necrosis, another is just inflammation, tubulointerstitial nephritis. There are two entities under the heading of tubulointerstitial disease. Okay. Now we are talking about acute tubular necrosis first. It has many synonymous: acute tubular necrosis, acute kidney injury, and it is the most common cause of acute renal failure. ATN, acute tubular necrosis, AKI, acute kidney injury, ATI, acute tubular injury. They are all synonymous and it is most common cause of renal failure. Now what happens in ATN? ATN is a clinical pathologic entity which is characterized clinically. Okay, we hardly are able to do any histopathological evaluation, so we have to understand this disease clinically. So it is a clinical pathologic entity which is clinically characterized by acute reduction of renal function. Okay, I hope you all know what is renal function. There is acute reduction of renal function, and sometimes there is morphologic evidence of tubular injury if we get to see the histomorphology. Okay, so what is the most important function of kidney? Yes, Ramita was trying.
Concentration.
Formation of urine, not concentration. Yes, tubule has the function of tubule is concentration of urine. I'm overall asking. So overall formation of urine, isn't it? So if urinary output is reduced, if patient goes in oliguria and anuria, and along with that there is many metabolic symptoms, then we have to understand that it is acute condition, acute kidney injury. Suddenly there is all those changes. This ATN is the most common cause of acute renal failure, and this signifies acute reduction of renal function, urinary flow. Within 24 hours, there is less than 400 ml of urine per day. The patient was previously all right, had some condition, had some disease or some illness in which there was rapid reduction of the renal function. Like if you do the blood investigation, the blood urea is increased, serum creatinine is increased, the sodium potassium are altered, and at the same time symptomatically there is decrease in urinary output. The urine flow is decreased within 24 hours or less. Okay, it may be 5 hours, 6 hours, 10 hours, 20 hours, 24 hours, but in less than 24 hours time, the urine output goes 400 ml, less than 400 ml per day. Understood? Now, this acute kidney injury or acute tubular necrosis is mainly of two types, okay, but I have categorized it into broad headings, 4 types. So the major 2 types are ischemic and toxic. Ischemic and toxic. Mind it, acute tubular necrosis can be either ischemic or toxic. The second other causes are inflammation, acute tubulointerstitial nephritis, in which in the heading of tubulointerstitial disease, we said there can be inflammatory disease, and the urinary obstruction. Okay, so you should not forget the ischemic and toxic one. All right. Now, what are the causes of ischemia? What is the causes of ischemic ATN? If there is involvement of intrarenal blood vessels by certain diseases like hypertension, the malignant hypertension, very high blood pressure, okay, microscopic polyangiitis, the inflammatory condition of blood vessel, vasculitis, or some other microangiopathies, if there is diffuse involvement of intrarenal blood vessels, then there can be ischemic injury, ischemic tubulointerstitial injury. Some systemic conditions like hemolytic uremic syndrome or thrombotic thrombocytopenic purpura. So you have to mention the yellow letters which are important cause of ischemic renal injury or ischemic cause of acute tubular necrosis. Then if a patient is in sepsis, will go to DIC, there is high chance that will go to DIC and subsequently will have acute tubular necrosis. Okay, all right. So there is overall the effective circulating volume will be reduced and there will be ischemic ATN. Now we are coming to toxic ATN. The toxicity is caused mainly by drugs and some therapeutic agents or diagnostic agents like radio contrast dyes, and certain diseases like hemoglobinuria, myoglobinuria. This can cause excess in amount. This hemoglobin and myoglobin can cause toxic injury in the respective diseases. Radiation, exposure to very high doses of radiation, whether it is therapeutic or it is bomb attack, okay, or it is some diagnostic tests like high density CT scan and all these can cause toxic injury to tubules and ultimately lead to toxic causes of ATN. Now comes to other diseases, other categories. Acute tubulointerstitial nephritis. It is most commonly occurs as a hypersensitivity to a drug rather than some organism. Okay, the organisms basically are responsible for causing what? Pyelonephritis, isn't it? The whole renal parenchyma is involved. Pyelonephritis. Why? Isolated glomerulonephritis or tubulointerstitial nephritis are autoimmune or immune mediated mechanism or hypersensitivity reaction due to drugs and many other factors. Then causes of urinary obstruction. It can be by tumors, by blood clots, because of the prostate hypertrophy. So any cause that can lead to urinary obstruction. Okay, tumors, non-tumors, whatever, tumors, prostate, prostatomegaly, blood clots, even calculus, big calculus, these can all cause acute tubular necrosis. So again, revising that acute kidney injury is broadly of two types. Okay, it can be ischemic or toxic. Second, two more common causes are tubulointerstitial nephritis and urinary obstruction. I hope it is clear to you all. Now, this acute kidney injury is responsible for 50% cases of ARF in hospitalized patients. Means the patient is hospitalized for something else, okay, had gone in hemolytic uremic syndrome or has gone in DIC or has gone in thrombotic thrombocytopenic purpura, okay, or has some other surgeries, complications of surgeries, drugs, therapeutics, diagnostics like radiation and all. So all those patients have very high, the critical patients have very high chances of going into acute tubular necrosis. So now again I am revising. I hope you will not miss this anymore, that it is broadly of ischemic and nephrotoxic type, the acute kidney injury or acute tubular necrosis. In short, we say ATN, and the mixed types are overlapping of ischemic and nephrotoxic, and then the other two types are tubulointerstitial nephritis and urinary obstruction. Okay, and in both cases, in both toxic and ischemic condition, what happens? Of course, in ischemic there is disturbance in blood flow, but even in toxic, ultimately it leads to disturbance in blood flow, and it will cause direct or indirect tubular injury. Okay. And why this tubular injury occurs so easily? Because the tubules are very sensitive to ischemia. The tubules are very delicate structure. If there is renal supply compromise, renal blood supply compromise, they are very sensitive to ischemia, as well as they are very vulnerable to toxin. If say in a medical school, the MBBS students frequently get headache because of different stresses, or they are unable to cope with the stresses of studies and all. And I have seen many students misusing the paracetamol. They think it is just paracetamol which is used for fever or headache or body ache, and they frequently take. No, don't take. They can damage your tubules and interstitium of the kidney. Tubulointerstitial toxicity occurs frequently with paracetamol, so it should be used as less as possible. For minor ailments, don't use any drugs. Okay, if the ailment is significant, the non-specific ailments, then only use drugs. Now pathogenesis again. So what happens there? Either there is ischemia or the toxicity, and both can cause damage to tubules. Okay, so ischemia causes numerous structural and functional alteration in the tubular epithelial cells. Okay, so these structural changes lead to first reversible injury. I hope you know the cell injury, cell degeneration, and cell death, the sequence from your first year. Okay, so initially there will be cellular swelling, loss of brush border, loss of polarity, bleeding, and cell detachment. And if in this time the cord is withdrawn, then probably the kidney can be saved. And if it goes further and there is lethal injury, after reversible injury there is irreversible injury, then there will be necrosis and apoptosis. So the tubular injury will be significant. Clear? Now, what biochemical changes occur in necrosis and apoptosis? There will be loss of ATP, there will be depletion of ATP, which is power energy of the structures, the epithelium, and intracellular calcium will be accumulated, the proteases will be activated. So it occurs in any cell death. The ATP will be depleted and there is amorphous calcium deposition, especially in mitochondria. If you remember the definition of cell death or necrosis, the irreversible changes occurs when there is accumulation of calcium. That is the no return point. Okay, so these all are the activation of caspases, reactive oxygen species generation, and phospholipase activation, cytoskeleton distribution. These all indicates that there is cell injury. Okay, and the electrolytes, the intracellular sodium potassium imbalance occurs. So I will just shortcut this pathogenesis. Okay, so mainly there is overall, because of the injury of cell, first there is reversible. In short, you can say first there will be reversible in cell injury, followed by irreversible injury, that is necrosis and apoptosis. So what happens? You have to mention this slide. In the remaining slides I just told you to understand. The injured cells get detached from the basement membrane, and from this you have to derive the morphology. So the injured cells, they get detached from the basement membrane and cause luminal obstruction. So further it will increase the intratubular pressure because of the accumulation of detached cells, and because of this there is overall tubular injury leading to decreased GFR. Okay, at the same time the fluid from the damaged tubules also leaks into the interstitium. What is the function of tubules? It causes concentration. The glomeruli causes filtration and tubules causes concentration, isn't it? So after the tubules epithelium gets detached from the basement membrane and they are causing obstruction, there can be also leakage of fluid into from the tubules into the interstitium. So overall there will be interstitial edema, increased interstitial pressure, and in the vicious cycle there will be further damage to the tubule. Alright, so all these things, whether it is increasing intraluminal pressure because of detachment of the injured cells, or there is interstitial edema, both of them are causing decrease in GFR, either by increasing the pressure, intratubular pressure, or by directly damaging the tubule, and all this causing the reduction in the GFR. Okay, so ischemic renal injury or toxic renal injury, both causes ultimately hemodynamic alteration and reduced GFR. Now, these are a little detail, okay, but I guess you people will not be able to catch it. So don't forget that there is overall hemodynamic alteration that will cause decreased GFR and further renal damage. So pathogenesis is there in your curriculum, so you have to understand that. Okay, you see this table. This table will help you understand the entire thing we just discussed now. You can take a screenshot or take picture of this. So you can go through this. Okay, this picture sequence, it is from Robbins only. You can check Robbins. Okay, and this is the sequence in acute kidney injury. So what happens, either whether there is toxicity or ischemia, in both cases there will be tubular cell injury, there will be reversible and irreversible courses of disease. Okay, in reversible there is loss of polarity, the distal sodium delivery will be increased. Okay, there will be detachment of cells that causes luminal obstruction and intratubular pressure we just discussed. All right, and in irreversible necrosis, either there will be necrosis or irreversible injury, there will be necrosis or apoptosis, which will lead to interstitial edema and decreased tubular flow, isn't it? Ultimately what happens, there will be reduced GFR and oliguria. So what we discussed for this chart only, I just tried to simplify this chart. So I hope there is no problem. You can go through Robbins also. Okay, now what happens in morphology? As we are saying again and again and again, at one side there will be detachment of epithelial cells and increasing intraluminal pressure or intratubular pressure. The other side there will be ischemic necrosis. Okay, so in a morphology also you will see same thing, focal tubular epithelial necrosis or multiple points at the multiple points with the skip areas, because the vascular injury may or may not involve uniformly. There are many vessels, many feeding vessels are there. So wherever there is involvement, there is rupture of basement membrane, detachment of tubular cells, okay, and occlusion of the lumen by those cast, means detached tubular cells. Cast are nothing, but they are detached tubular cells. All right, so this is morphology from pathogenesis. Okay, and if we divide it into ischemic and toxic, basically in ischemic, what will happen? The straight portion of the proximal convoluted tubule and ascending thick limb in the renal medulla are especially vulnerable. So that is kind of a quiz questions, and if anyone is interested, so quiz question means kind of viva question which is tricky. So if the students are answering well in the viva, then examiner may go for this question. Otherwise you should not take much stress to remembering the particular part. But yes, the proximal tubule and ascending limb, they are very vulnerable. Okay, while the lesions that occur in distal tubule, okay, they act as the conjunction along with the cast. Now what morphology we see in urine analysis or in morphology, as we are saying again and again, that there will be detachment of tubules, that tubules get lost in the lumen. Okay, it increases the intratubular pressure. So all the tubules which are tubular epithelial cells that are detached will act as a cast. They will take shape of the tubular lumen and act as a cast. So there will be formation of eosinophilic hyaline cast. This, notice this red is very important and blue is important. So eosinophilic hyaline cast is very, very important. That indicates there is ischemic acute tubular necrosis. Along with that, there is pigmented granular cast, okay, in distal tubules and the collecting ducts. And this is shortened question in this chapter, that we see TAM horsefall protein. Okay, this is TAM horsefall protein from this cast, from this urinary glycoprotein, okay, that is secreted in ascending limb and the distal tubules, along with other plasma proteins. The cast that is made is called TAM horsefall protein. So the question can be, what do you see, what cast, what kind of cast or what kind of proteinous material you see in acute tubular necrosis in ischemic variant? So you have to say the eosinophilic cast and the granular cast in the form of TAM horsefall protein. At the same time, vice versa question can be asked, where do you see TAM horsefall protein? So you have to say in the context of ischemic ATN, isn't it? So other is edema and accumulation of neutrophils or neutrophilic leukocytes and all. Okay, so these are non-specific feature. What was important was this: the cast, okay, the necrosis, loss of basement membrane, all these things are more important. Now toxic one, which was called till now we were talking about ischemic. The toxic one, this is caused by drugs, radiation, or other kind of toxicity. Okay, in contrast to the ascending limb and the collecting tubule of ischemic, it is mostly common in PCT, proximal convoluted tubule, and it's directly shows tubular necrosis. Just like in poisoning, it shows necrosis, and once it is necrose, it appears as a large acidophilic inclusion. So what do you see in any kind of necrosis? The entire thing becomes pinkish, eosinophilic, isn't it? So the cells which are necrotic, they get desquamated in the lumen, and for if they remain for the long time, they will go under calcification, and that calcification is known as dystrophic calcification. Okay, so it's just example that if it is mercury chloride, then there will be large acidophilic inclusion. If it is, there are many poisoning that comes with acute tubular necrosis. So in toxic, you can add the toxicities by drugs, by radiation, and the poisons the people ingest for societal purpose or industrial exposure, like that. Okay, so some of them are mercury chloride, carbon tetrachloride, isn't it, ethylene glycol. So all these causes, so you don't need to remember the individual. Overall, there are eosinophilic inclusions, necrosis, all these things. Now see this picture. This is also from Robbins, and you can understand which part is involved in the ischemic type and which part is involved in toxic type. So in ischemic type, there is mostly involvement of proximal convoluted tubule in toxic type, proximal convoluted tubule, while you see the ascending limb, some portion of proximal convoluted tubule, basically the ascending limb is involved in ischemic type. Now another important feature in pathogenesis, the conclusion is it is of broadly two types, ischemic and toxic. You have to understand the causes of ischemia, the HUS syndrome, the TTP, DIC, malignant hypertension, any other renal vascular disease like microangiopathies, polyangiitis, isn't it? Or all these kind of vasculitis, they all cause ischemia. Toxic, there are many drugs, there are radiations, there are poisons. Okay, then came the morphology. There is injury, either direct injury or ischemic injury, desquamation of tubules, accumulation in the lumen, formation of cast. In the, especially in the toxic where there is direct necrosis, direct toxicity is there, there will be eosinophilic cast formation. All right. Now we are coming to acute renal failure, which is caused by acute kidney injury. So the clinical course, the disease is acute kidney injury or acute tubular necrosis. As the name is saying, ATN, necrosis. So there has to be necrosis. There will be cell death in the form of necrosis and apoptosis. Okay. Now, how will this clinically present with the ARF, acute renal failure? It will have three phases: the initiation phase, the maintenance, and the recovery stages. Okay. So this is again very important. So first 36 hours is dominated by the initiation phase, in which whether what is the event that caused acute kidney injury, whether there was some medical disease, whether the patient underwent some surgical or obstetric event, okay, that lead to the ischemia. Suppose someone had CS, cesarean section, or had hysterectomy, the removal of the uterus for some benign lesion. Ultimately, what happened? There is ischemic tubular injury because of some surgical or medical event. So what will happen? The renal involvement, we are very worried about urinary output in a post-operative patient. We see the renal output, we catheterize the bladder, we measure, even if the bladder is not catheterized, in the post-operative ward, we measure in the measuring jar or jug or whatever measuring scale is there, we measure how much ml of the urinary output has come. So decrease in decrease in urinary output is the first sign of acute kidney injury. Okay, so at that time we have to infuse the fluid, we have to check for the causes. If we can check at that time, there may not be the progression. Okay, that is called maintenance phase, the progression phase. Here in the initiation phase, first will be oliguria, and there will be transient. It is because of the transient decrease in the blood flow that lead to the decreased GFR. What did we say in the pathogenesis? Ultimately, whether it is toxic or ischemic or whatever the cause, there will be decrease in the GFR. Okay, coming to maintenance phase. Maintenance phase is characterized by the decrease of output, which is between 40 to 400 ml per day. That is oliguria. Less than 400 ml is oliguria. Less than 40 or 50 is anuria. So it should be 50 to 400 or 40 to 400, depending upon the laboratories. They are following the parameters. And at the same time, there will be salt overload. Means there will be increased blood sodium, serum sodium. Okay, blood urea nitrogen concentration will be increased. Potassium. Hypernatremia, hyperkalemia. Natremia means sodium is increased, kalemia means potassium is increased, BUN means blood urea nitrogen is increased, and metabolic acidosis and features of uremia are there. Okay, now in this maintenance phase, if the initiation phase it could not be checked along with oliguria, if all these things has come, that is maintenance phase. Now if patient recovers, what will happen? The volume will gradually increase up to 3 liters per day. Okay, 2.5 to 3 liters, that is normal volume. But the tubules are still damaged, and so large amount of sodium, water, potassium are lost in the urine. Okay, the electrolytes are getting lost in the urine. So the recovery phase, what happens? The potassium which was high in maintenance phase gets down because it is getting loose in urine, so there will be hypokalemia, and the patient is very vulnerable to infection, so we have to save the patient from the infection in the recovery phase. Ultimately, if the patient survives this severe injury, there is ideal treatment, appropriate treatment, then eventually the renal function is restored, the concentrating, all right, they are not oliguric. So this is called non-oliguria ACI or ATN, which occurs usually because of the nephrotoxins. Okay, and with the supportive care, and if there is no shock or sepsis or some very comorbid factors, then 95% of the patients get recovered. All right, so these three phases, that is very important. If it is 1 marks question, you can just mention the 3 phases: initiation, maintenance, and recovery. Okay, if it is a little bit elaborative, you have to elaborate it that the initiation occurs because of some medical or surgical events that ultimately lead to tubulointerstitial injury in the form of ischemic. You have to mix the pathogenesis in explanation of these phases, how this occurs, isn't it? Now, how will you identify initiation? By oliguria, decreased GFR, and rise in blood urea nitrogen, isn't it? Then comes maintenance. The oliguria keeps on going, okay, keeps on going, and along with that the other parameter, the sodium, potassium, blood urea nitrogen, all these things, metabolic acidosis, all those go on rising. Then only comes the recovery phase in which the urinary output is restored. So it is simple. You have to just understand how this happens. If we have less than 1 minute time, so if you have understood this sequence, okay, you can easily answer, and this is very important. In fact, the renal chapter overall is very important. You cannot predict which question will be asked. The glomerulonephritis, the renal failure, pyelonephritis, tumors, everything is very important. But this is important in your day-to-day practice. If you will be a clinician, for each and every patient you have to rule out ATN. Okay, any admitted patient, any severely ill patient has to be evaluated whether he is going in ATN or not. So this is for your clinical knowledge also, and you should be very much aware of it. All right, clear? Any question till now?